Good morning, ladies and gentlemen, and thank you for your commitment to be here today for this important function. First and foremost, before I make any substantive remarks and eventually introduce our panel, there's something I want to say because, you know, as Surgeon General of the United States, you have a lot of responsibility, but you're humbled every day with the complexity of the world. And it's people like Joe Kiani that make the job of Surgeon General or Health Secretary a lot easier. Because government has a role, but really the change that comes about in this country and what makes our democracy so great, I believe, are the innovators, the entrepreneurs like Joe, who are willing to put their time and their money and their expertise on the line. They see an issue and they drive it hard. And like he said, starting with a little summit, now we have a national and probably a global movement before us. So Joe, on behalf of all of my colleagues, I thank you for sticking to this because this is one of the most important problems we face as a nation. Thank you very much. Last year I had the privilege to come and speak as well. And like most people in my position, we get lots of opportunities to do public speaking on issues that are germane to the health of the nation and global health. And Joe reached out to me, and I had heard about the summit. And I wasn't sure, but I thought, let me give this a try. And I was so overwhelmed with what I saw and the importance of the work that was being done, I also made a commitment to Joe to do whatever I can to move this forward. But after that conference last year, Joe and I had a conversation. And he said, Rich, what do you think about next year? What should we do? How can we grow this? I mean, I saw the passion in him. He just wanted this thing to take off. And I said, well, Joe, you know, maybe next year I could do a presentation on some contemporary issue. And maybe we'll have a panel and I can facilitate some questions. And we'll get the audience involved and have them asking questions. So we ended the conversation. He says, well, let's see what happens. Maybe something will come along that we'll be able to center this panel around. And there was Ebola that came out, and we all rode that wave for some time. We're really fortunate today that we have an expert panel that you'll meet in a little while who will have a conversation with me about some of these issues, and then the last few minutes get some questions from the audience as well. So what I'd like to do is frame the issue for you now. As I said, you know, as Surgeon General, you have so many inputs coming at you every day, from global health to national health, weapons of mass destruction, terrorism, obesity, cardiovascular disease, patient safety. And what are we going to do about it? Interfacing with your colleagues at CDC, HRSA, SAMHSA, NIH to try and find the solutions. And being Surgeon General is you age in dog years in that position. You often feel, I used to jokingly say, like a cemetery caretaker. Well, there's a lot of people under you, but nobody's listening. And so it becomes a frustrating experience, yet we keep driving because, like me, I never lost sight of the fact that as the 17th Surgeon General of the United States, I was only the 17th person in the history of the nation to have the job. And what a position to be a physician, to have the responsibility for the health, safety, and security of the nation and try and coordinate all those resources to reduce morbidity, mortality, and improve health, quite frankly. So this issue today with Ebola, as you saw, everybody became Ebola expert a few months back, every reporter, and yet it's a very complex issue that's been before us for a long time. And really, Ebola isn't the issue because it's emerging infections. For those of us who live in this world of preparedness, Ebola represents but one pathogen that happened to make its way across the world and infect a number of people. Now, I'm not minimizing it, but think about this. You've heard about AIDS and SARS and avian flu. These are recurrent themes in our society. They don't go away. The real issue is, what is the infrastructure that the nation has to deal with emerging infections, whether they are naturally occurring mutations or man-made as a terrorist event, as a bio-event. It really doesn't make a difference at that point because the infrastructure is going to respond the same way. The experts will be there, the EMTs, the paramedics, the whole continuum, which starts with prevention, response, mitigation, and then recovery from any and all hazards. So that's the term that we use at a national level. And after 9/11, we spent billions of dollars injecting that into our public health systems, which, as you know, were crumbling at the time. A lot of public health departments were closing. States were taking on bigger responsibility for public health in a state. We were really struggling. But with the injection of these billions of dollars, everything from pre-hospital care to the health professionals in the hospitals and clinics to the social support services were built up in order to respond to any and all hazards. And that was important because of the threats before us. We were really keying on terrorism, the weapons of mass destruction, nuclear, biological, or chemical, which are the unconventional weapons, or the conventional weapons of mass destruction, which are bombs and bullets and fires, explosions, things like that. Nevertheless, the nation, you the people, we the people, expected that our nation would have an infrastructure in place to respond to any and all hazards that we would be challenged with. And that all hazards preparedness begins with a national response framework, a national incident management system, which is essentially the incident command system that you use in all your communities, put on steroids and blown up to scale, that covers the nation, and we surge, we all come together, we share the responsibility for large geographic areas, for instance in Katrina, or a tsunami in Indonesia, because let's face it, we are the world's responders, we are the world's doctors, we are the world's police, fire. The world depends on us. And often the best practices we promulgate are ones that are adopted. As Surgeon General, I traveled the world sharing our emergency plan with our colleagues, our allies, to make sure that it was a seamless system so that when something like Ebola occurs, we have early warning that something's happening. We are ready and prepared to try and prevent anything from happening in this country. And if something slips in, we have an infrastructure that will deal with it. Not just because it's Ebola, because it's any pathogen that came our way. So today in the panel, we'll discuss with the experts this idea of Ebola and all hazards, but in the themes of today, of this conference, about sepsis, about assertiveness, you'll see all three themes in our discussion, because assertiveness is important as to how we responded to Ebola in this country. The real challenge now, what are the lessons we learned from Ebola? What are the lessons we learned to improve patient safety, to prevent things like this happening in the future? Nobody's perfect. It happened to happen in Texas, that they became the highlight of what was going on, but if it was in New York or California or Minnesota, we would have gone through the same process. Because after we did all of that training after 9/11 and ramped up all our systems and educated everybody on personal protective gear and how to take it on, take it off, what to do to prevent an infection from spreading, nothing happened for about 10 years. And we became complacent. And people forgot. And new nurses were hired, and new doctors were hired, and new technicians came in. And they knew there was emergency equipment, and there was this gear over here, but I haven't put it on for a long time. And then the emergency hits, and you put it on, and they go, okay, well, just put some tape over here. That'll be okay. And let's do this, and let's do that. And we jimmy-rig things, and therein lies the problem. Because we lost the focus on the expertise that we had developed, and because of that, patient safety is jeopardized, because we have cracks in the system. So today, we'll have that discussion. So my panel, come on up. Come on up. And you'll see our panel members up there, so you're not going to spend a whole lot of time on introductions, but these guys are terrific. They were in the center of all of this work today in different disciplines, and it demonstrates how patient safety is a multidisciplinary response. Majid, good to see you. Please sit down. Thank you. Thank you. Come on up. Shruti, please. Arun, thank you. Marleece, please. Okay, thank you.
You're on this side.
There we go. Everybody slide down. I'm on number 5, so move down a little bit more. Okay, right. There we go. Okay, so since the center of our discussion is really about lessons learned from Ebola, maybe I will start my first question with Shruti. Tell us what this Ebola thing is. Why is it a problem?
Well, Ebola is, as we all know, a highly fatal disease. It's a viral illness that spread by contact, and it has a case fatality associated with it from anywhere ranging from 25% to 90%, depending on where you are and what the outbreak is. And this current outbreak, as we all know, is unprecedented.
So virus, bacteria, what is it? I mean, for the people who aren't in microbiology, biology,
yes.
what is it?
It is a virus. It is a virus, and it's transmitted through contact with secretions, vomit, diarrhea, body fluids, most commonly in that form.
So now, Majid, where's this come from? Tell us about the globalness, because today the world is flatter. Okay, we're all interconnected. The threats and challenges we face as a nation don't respect our geopolitical borders. Tell us about it. You've had the experience overseas.
Certainly. This is very ancient, old virus. In a matter of fact, we learned about this virus in 1976. Even before that, in 1967, in Marburg, in Germany, many of the employees of a vaccine-making company, they did come down with this disease. And then when the scientists, they were looking under the microscope, they saw a gigantic, filamentous, ropey shape, never seen before virus. And that's the reason they call this virus filovirus, because it looks like a filament. And then in 1976, suddenly, after 9 years, in 2 places, one in Congo, those days obviously Zaire, and one in a village in south part of Sudan, another virus, but similar to Marburg virus, just merged. And because the village that gave birth to this virus was by Ebola river, this new virus was called Ebola. And then 25, 26 times over the history, this virus jumped up in very tiny communities. Nobody knew what's going on. But then finally they understood, in a matter of fact, maybe this is in a bat. And then finally they basically proved that certain number of the bats, certain species of the bats, I would say mainly fruit bats, they carry the virus. And this is the human that goes to the rainforest and then some way, somehow comes in contact with this virus that still is mysterious. We do not know exactly how the virus is circulated itself in the bats and in the wild. But then we know maybe the fruit bat chews on a piece of the fruit, and then fruit drops. That fruit is contaminated, would be consumed by antelope or by monkey or by gorilla. They acquire the disease like human. They are innocent bystanders. And then the poor people in these communities that you are looking for any protein, they basically butcher the monkey and then prepare the meat. And then during process of making the food, not by eating the food, they come in contact, unfortunately, with the virus, and then they come down with the virus. And the virus is not, to be honest, scary. I want just to tell you why this virus is not scary. Because the first case this time, it happened in a tiny, tiny village on 24th of December of 2013. And imagine up to the end of the March of 2014, for 3 months, the virus was completely unleashed. And less than 50 people in those poor community, they did come down with Ebola. So that's the bad, and then unfortunately, I would say poverty, and the lack of the infrastructure, and also the virus in this part of the world, in West Africa, was completely new. During the summer of 2014, there was an epidemic in Congo, but in less than 2 months, really, the epidemic was completely confined, but not in West Africa, because nobody believed in Ebola. Never been a problem in that part of the world.
Well, Majid, it's really interesting, because what we see is a virus that was discovered in the mid-70s. We go 40 plus years. There's a couple of dozen outbreaks in that area, and they're all contained within West Africa by groups like Doctors Without Borders and local health officials. Even though there wasn't an infrastructure, they managed to contain it.
Yes.
What's different today is somebody who is infected gets on a plane and arrives in another part of the world, and the incubation clock is still ticking. And they look fine. And then they get sick and they land any place in the United States, in this case, Texas. And now we have a public health problem. Dr. Patel, tell us about the public health implications.
Well,
tell us what your thoughts are, especially in LA County, such a big county that had to be prepared for this.
Yeah, so but I'll talk just a minute both about the public health and about sort of the health system. So, obviously, as you alluded to the media and everyone becoming an expert, everyone also became a potential victim. Everyone became very afraid that they or their neighbor or the guy down the street or the person in the store selling them their coffee or whoever it is may have Ebola. And so, as a public health matter, you have to think both about how to keep people safe and in cases like this, keep track of people who are moving around because, as you say, we have a longish incubation period, and how to keep people confident. I mean, we actually do have a pretty good system in place to keep track of who comes from West Africa, to know where they go, to make sure that they are following their symptoms, they know what symptoms to look for, that the local health departments know to follow them and to work with their local hospitals like ours if they need help in caring for these patients. And then, we have a lot of support as health systems from national, from the CDC and from HHS to make sure we understand how we can respond safely.
So let's look at the issue. That first index case shows up in Texas. People are worried, and some of the first barriers that we responded to, and I know because I started getting calls and some of my colleagues started getting calls, and the whole issue of crisis communications. We had patients trying to assert themselves. Okay, they were asking questions. What do I do? How do I protect my family? How do I make sure this doesn't spread in my community? We had physicians, we had health professionals that weren't sure. They heard about this, and yet we had a lot of different, we'll call them talking heads, giving information, sometimes stepping over each other, eroding the confidence of the American public and who's really in charge. What was the message? What should I do? And then, of course, we look into the business world, and we have the issue of continuity of operations, as we used to call it in business or government, because especially with the big defense contractor, you got to stay in business because the nation still requires us to be kept safe. And yet, how do we deal with that in that area, for instance, in Lockheed Martin, where those engineers have to keep coming to work and we have to keep doing those good things to keep our nation safe, and yet we're threatened with a virus that's hit the country. We don't know how it's spreading. There's a lot of confusion. So as a chief medical officer, how do you deal with that in corporate America?
It was definitely a challenge, and as you mentioned, our primary concern is the safety of our employees and business continuity. So when the index case landed in Dallas, that's the place where we have our largest operations. We started getting lots of questions from our employees, not only in Texas, but across the country. And we have 110,000 employees. So it was important for us to right away convene our all hazards team. And our all hazards team consists of members of the head of HR, safety, supply chain, and our security department. And we immediately began to locate our employees. Were any people in harm's way? Were they working in any of the impacted areas? What was the situation in Texas? Did we have any employees who were in the hospital that might potentially come into the workplace? Because everyone knew someone who was close to someone who had cleaned the apartment of Mr. Duncan.
That's exactly right.
And, and they were concerned about that certain employees, whether or not they had come in. So communication was really key.
Yes.
And we really had to exercise discipline. We had, I was the spokesperson, and we had a meeting every day, but we all decided on what would be communicated. And we relied heavily on information from the government. We didn't want to create our own policies and protocols, so we really relied on information from the CDC.
Well, let's talk about the communication. I think you said a key thing that when I did the post-mission, if you will, evaluation with some of my colleagues, the communication was kind of choppy. And I think you said a key thing that You were designated the spokesperson for your organization. You got all the information and filtered it, but your employees saw one person with a single uniform message giving them direction. As they asserted themselves to you to say, what do I do? You were right on task with that message. And one of the challenges that we had, especially in a big United States where everybody has an opinion and speaks out, and we have lots of good people who were trying to provide good information to assertive patients, and they were getting mixed information. They weren't sure. People were told to stay in place. Other people were told it was okay to travel. And as you said, I got a call from an auto dealer telling me they were having a continuing education program in Dallas. Was it safe to send his people from around the country to Dallas? And it was so far-fetched. And I had other people say, we have some people that moved in a couple of months ago from Africa next door to us. Am I at risk? But what it tells you is how poorly informed the public is, and that causes a lot of anxiety, stress. And of course the press is writing on all of this, and the stories are getting published, and it really drives us to a point where we have an obligation to be able to answer our public who is asserting themselves with good information so that they can make good decisions. So as we saw this spread, we saw a lot of mishaps. And so Ebola really tested our system, is what it did. It's the first time since we put together the all hazards preparedness that we had an actual test to say, does it work? Where are the pitfalls? So from a public health standpoint, Dr. Patel, tell me, as you saw this evolve, what did you learn from the mishaps that occurred by good people, but unfortunately we became complacent?
Yeah, and I know we talk about complacency and apathy, and they're sort of apt terms, but at the same time, I don't think that it's not true that any of us come to work in the morning and think, I'm going to hurt somebody, either by accident or on purpose, right? We need to be aware that it can happen, but no one sort of says, well, I don't really worry about that. But what those terms highlight is that there are things that we can do. We know in many, many cases what we can do, and as I've talked with other people, protecting staff and other patients in the public from Ebola is actually conceptually very simple. All you have to do is protect the mucous membranes of a healthy person from the bodily secretions and fluids of someone who's infectious. For the vast majority of us who are not living in West Africa in the jungle, that's all you need to do. It's simple, one sentence. Now doing it is really, really hard. Okay. And that's one of the things I think we learned, that we need an extraordinary amount of communication and coordination in order to handle these kinds of things. And we also have to have an extraordinary level of attention to detail. And I think as much as anything, we were challenged by how much we had to attend to the details of putting on your PPE, taking off your PPE. Where do you put the machine? Where do you throw away the garbage? Can you flush the toilet? Can you not flush the toilet? Which one of those two is safer? I mean, these are all things that we take for granted. And when we're faced with something like this, we realize that there are things that someone thought about. We're happy with the solution. We don't think about it very much, but at times we may have to think about it again.
Right. So as it relates to the three principles we're talking about today, and that, the assertiveness and resuscitation and sepsis, Ebola has the potential to cause sepsis. So if it goes unchecked, what happens is we start to see organs fail. The virus replicates in the cardiovascular system and grows, and so you get real sick and you get septic, or you have septic shock. And of course that requires resuscitation. So there's a whole continuum there that we're dealing with. Shruti, tell us from the infectious disease standpoint, how do we evolve there from that person that gets Ebola and it's not just to manifest as a more or less a common cold, but that goes on? What happens in the immune system? Why is it that this can become catastrophic?
Absolutely. So to go back to the previous question as well, the virus comes on, you come into contact with it, you may be feeling fine for some period of time, up to 21 days in fact, and then you start with this cold-like symptom, maybe some fatigue, some runny nose, and then that progresses to fever. Really what happens is the immune system takes hold, is quite aware of the situation, and it really reacts to the Ebola virus. Not only does it react to the Ebola virus purposefully by releasing a bunch of chemicals in your organ systems, particularly your liver, that lead to low blood pressure and difficulty with breathing, swelling all over your body. In addition to all of that, Ebola actually invades the vasculature and causes a primary drop in your blood pressure, bleeding into your organs. And so all of these aspects then start to dovetail into a situation where you can quickly get out of control. Sepsis, so-called sepsis, as well as nausea, vomiting, diarrhea. And it's actually in the height of all those secretions and bodily fluids that you are most infectious. And it really presents a challenge to healthcare workers who then have to take care of ill patients who are at the height of their infectivity.
Yeah. The interesting thing is, I know there's a group we'll be talking about resuscitation later. The simpleness of this whole thing, resuscitation is really just keeping up with the body fluids loss. Yeah. Because, you can argue whether or not antivirals will help a little bit, but really it's about sustaining life through this overwhelming immunologic challenge and replacing fluids. It's a real challenge for all of us. So as we go past that, one of the things I want to ask Marleece about is, I mentioned it earlier in my questions, this whole concept of when we have a national emergency and we have to scale up, so we surge, and different health departments have to talk to one another, and as we keep moving up and up that chain, this issue of continuity of operations. People don't think about that often, but when we have something like Ebola or any emerging infection that isn't controlled well, or if it's a terrorist event, government has to stay in operation, corporations have to stay in operation. Maybe you can just mention a little bit about, without divulging too much information, but your internal structure for continuity of operations when a big threat comes along from all hazards, any hazard.
Sure. So the biggest concern was around travel and working with contractors. And we put policies and procedures in place to make sure that we were monitoring where people were. You had to have approvals to travel to any of the Western African countries, and we monitored those employees throughout their travel. We also required them to refrain from entering the workplace for 21 days. And this was a bit controversial, as you may remember early on, because people felt that it may be discriminatory. But when you're dealing with 110,000 people, we felt that we really had to balance the interest of the majority of the people. So we put those kinds of processes in place. The most challenging for us was as we looked forward and wondered whether or not the Ebola crisis would continue to unfold, we were approaching flu season, and we were really unclear as to how we would screen people in the workplace and triage them with flu versus Ebola. So we made some investments in temperature scanners so that we could minimize contact with the healthcare provider. We have 28, I forgot to say, we do have 28 on-site wellness centers, so employees get some healthcare at work. But beyond that, the issue of investing in PPE came up. We had personal protective equipment.
Good.
We were prepared for avian flu, but not Ebola. And this is the kind of thing that you really have to weigh the public's health and a company's investment, because if you buy lots of PPE, as we bought lots of antivirals for the avian flu, some of it goes wasted. So you've invested millions of dollars and it's unused. So that presented a dilemma for us.
One of the points you bring out that's really interesting is, and we see it in every disaster that we have, especially those involving bioagents, or when we do modeling tabletop, is the worried well. Mm-hmm. Because at a flu season, you have Ebola coming in, and everybody with a runny nose or a fever thinks they have Ebola. and they know that they've passed by somebody who came from Africa, who got off that plane,
Yes.
and they connect all these dots that don't connect, but yet the real challenge there is that it creates a great burden on all of our emergency departments and our healthcare departments because of the worried well. Did you see any of that in LA?
We saw a lot of it, both really among the public and our patients, and also, as Marleece has described, among our staff, who were quite concerned that that they might simply be at risk for infection because we were screening people, or we were having people come in with symptoms and putting them in isolation temporarily while we figured out that they didn't have Ebola. People were worried that if there was an Ebola patient in the hospital, that they working in some other far reach of the hospital would be at risk. So we saw a lot of that. And a lot of what we did was what you mentioned, is communication and education to make sure that people really understand who is at risk and who is not. So that they know they're safe, and we can carry on focusing on the people that we do need to think about who may be ill.
Well, I think it'd be worthwhile also to talk about the United States response to this, because there was a lot of questions. We mobilized our military, our U.S. Public Health Service. People thought that that was odd, that we were sending our resources to other countries or country when really we needed them here. And yet, for those who deal with emergency management preparedness, especially with emerging infections, we recognize the best way to contain the infection is to contain it where it started, rather than letting it come here and figure out how to respond. So Army, Navy, Air Force, U.S. Public Health Service are sent, as we say, downrange. They start building hospitals and clinics, building an infrastructure, water. As Majid pointed out, there was very little infrastructure there, yet miraculously, for 40 years, they have managed to contain dozens of outbreaks right there. It never left. This time it snuck out. So we reached forward and we sent the first group of people that went down, that actually provided the care, were U.S. public health officers, and Army, Navy, and Air Force people were supportive. And then, interestingly, as it went along, one of the things that we recognized was one of the biggest risk factors for the people there to transmit the disease were their burial practices, because that's how most of them were getting it. You want to talk about that, Majid, how it was spread locally?
Really, first I would like really to comment on young American servicemen and their role really in West Africa. First time in East Timor, really, I met this young American serviceman, and I had so much really admiration for their talent and their passion. In West Africa, and these are young American servicemen, women and men, probably 24, 25, and they were first very much involved in training of not only expatriates, many of the Liberians or national people from West Africa, that finally they are going to work in ETUs. And the second, they built beautiful, I would say, a state-of-art ETUs. I want to say that most often really when you look into the literature, ETU is a bad terminology, is Ebola treatment unit. In a matter of fact, is not treatment unit, or was not treatment unit. It was confined unit. American built ETUs, they have ACs, they are roomy, they have plenty PPE. There is continuous training for everybody who works in ETU. And they have really every medication that you wish that somebody may have. Thanks to God that really, for all of these efforts, and you know that Ebola now is going away, particularly in Liberia. In the last 3 weeks, we never had more than one case a day in entire really country of Liberia. And imagine sometimes it was hundreds of them daily, even in Monrovia. And also I wanted to say something else because I think it's very important for the people to know. Because just I came to John F. Kennedy on December 13th. When I was going to Liberia, I knew my American citizen, rightly, they are going to have mixed feeling toward me. please go, God bless you, you are doing good job, but please stay there, don't come back. I did come back, and immediately as soon as I came out of the plane, the security guards, they came and asked all of the passengers to open the passport. They were looking for my name, and those people who are coming from West Africa, they cohort us, and then they were interviewed by CDC members very courteously, just a few health questions, and then they gave us basically one cell phone, and they said, listen, this is your cell phone, somebody is going to be in touch with you twice a day, you have no movement restriction, you can go anywhere that you want, because as long as you are monitoring your temperature twice a day, and you're going to report your health status to somebody. I told them that I'm going to go to Connecticut, they knew that I'm going to go to Connecticut, and they told me that a state of the Connecticut public health principles and the rules and regulations equals to CDC, because we know that each state probably has different sort of the policy in place. I was home, and then immediately next morning, somebody from Department of Public Health from Connecticut got hold of me and then interviewed me more and told me by the end of the day somebody is going to tell me what I need to be doing and what I shouldn't be doing. And then at the end of the day, basically, they basically was completely in harmony with the CDC decision. I called work, but obviously they told me please stay home for 21 days. Though basically CDC and also the public health department, they told me I do not have any movement restriction. And then I had a niece in school in Farmington, 50 miles away from my home, and she was so concerned because the kids in school, they learned that, I have been in basically Liberia, and they want to know exactly whether I'm going to be home, I'm going to go to the public, and then it's Christmas time, and my neighbors were really concerned. They were talking to my wife, and then I thought, really, I'm not going to go really out of home, not because I didn't know that I'm not contagious. Somebody from public health was basically monitoring me, and they made it completely clear. If I'm not going to follow the rules and I'm not going to call them, then they may come even take me away. But as long as I'm basically compliant with the rules and the regulation, I can stay home. So basically, I said to my wife, really, I'm not even go home, out of home, because I do not like really to make Christmas party for my American citizen Halloween, basically. But the system is in place, and I was completely secure. I knew that they were taking care of me, and the public health policies was in place. And I can't imagine with the policy that we have right now, anybody in the United States would come down with Ebola, and if he comes down with Ebola, it's going to be any threat to any public.
Thank you, Majid. Now, so let's, just a couple of things. I think we've covered the waterfront on Ebola, just the general nature to bring everybody up to speed. Like Joe, I have a particular affinity for assertiveness. And one of the challenges we had during this challenge was there were lots of people asserting themselves out of fear, unfortunately, and trying to get information, and we're not getting good uniform information, that we were stepping over one another. Should I stay home? Can I go to work? Can I get on a plane? And so on. But to Joe's point again, one of the things that we didn't do during this challenge was to use technology to our best advantage. It's pretty simple to put a chip on somebody and know where they are all the time, and to have a sensor on them that will allow you to be able to track temperature. So we've been working on these things now as a matter of, for a next time event, to have an infrastructure in place where anybody that's at risk just gets a little band or a Band-Aid on them. You can transmit temperature, you can transmit vital signs, you can transmit exact GPS location. So basically with technology, we can make it a much safer system. We can make it safer for our patients and take away some of the uncertainty from all of these questions of who's moving where and what the risk is. So what I'd like to do now is maybe go to some of the questions, because we have some great questions here. And I think that, I'm not sure we're going to get to all of them, but boy, they're terrific. Let's go this. Mark asks, how does the infection of the nurse in Dallas correlate to overall in-hospital communication and assertiveness? I think that's a great question because the nurses did assert themselves. Anybody want to start?
I'll start, though. It's a very difficult question. To their credit, nurses recognized that they were the people who were probably most at risk in caring for an Ebola patient, and they were very assertive, and in some places continue to be fairly assertive about the need to make sure that they were safe. And the way we responded to that was, A, to make sure that we could keep people safe, and to do as much education as anyone wanted. I told our representatives for our workforce that anytime they wanted me to come talk about Ebola and how we were responding and how what we were doing to keep our workforce safe, I was happy to do it. We took their suggestions, right? Once we started actually working with the personal protective equipment, we took their suggestions. We showed them how we'd all been instructed to use it and put it on, and they said, well, maybe if you did this, right? Or we showed them the space where we would care for a patient. They said, right, maybe if you put that over there and go in this door instead of that door. And so, it was sort of an assertiveness from their side saying, we want to be part of this process, and we are concerned about ourselves. And from our side, as the system and the system administrators and the physicians saying, yes, we want you to be involved. We want to do what we need to do to make sure that you feel safe. And we want to use your knowledge and your perspective to all of our advantage.
I think one of the things that I noticed most that I was most pleased with, National Nursing Organization stood up right away and said, wait a second, my nurses are at risk. Many of them have only gone to one class. The people that are telling them what to do are telling them the wrong things to do. And really that was a driver to be able to change the system. And to Joe's point in picking assertiveness as one of these areas that we need to push on today, it's incumbent upon all of us to speak up when we see something being done wrong or something that is just not correct for whatever the reasons, and we can do it better. But I give great credit to national nursing organizations who stood up and said, our nurses are willing to take risk and care for their patients, but we have to be able to reduce that risk as much as possible based on the best science. And at that point, we weren't practicing the best science. Another great question here is one that I got a lot when this was happening this is from Terry. Why did we choose to bring those affected to the U.S. for treatment? Which became a very contentious issue because unfortunately, a lot of Ebola became political. We had health directors that firmly were giving information, and then political leaders who said, no, I'm not going to do it that way, and decided to sequester patients in a tent, or make everybody go someplace, and really defying public health principles, but they were looking at it through a political lens. So I think that's another issue that comes up in all of these big issues. Ultimately, they do become political, and people are worried about votes, and people are worried about parties, and that's just the reality of it. But those of us who have the privilege to serve at whatever level we're at must be assertive, because our focus is not on politics. Our focus is on actually making it safe for the patient all the time. So let's talk about that. Why was it that patients were brought here? Shruti, you want to start?
Sure. It seems pretty clear that with very aggressive supportive care, that patients will do reasonably well with Ebola, especially if you catch people early. And so particularly in the first few cases when the patients who had been brought over came over and they had their serum and from other Ebola patients and were given that serum along with aggressive supportive care, our fatality rate and when we take care of patients in the United States has been very, very low comparatively. So you can imagine that would be an optimal solution if you came down with Ebola and you happen to be abroad. I do want to say that there are many issues associated with patient safety as well as healthcare worker safety when you're taking care of patients like that, and the decision to bring patients like that over, and what your infrastructure is to take care of patients like that. Boy, Ebola really challenged hospital infection prevention, particularly in our hospitals. It's sort of, I like to think of it as sort of the HIV of our field. It really led us to scrutinize every aspect of what we do, why we do it, all of our practices, very much to what Dr. Patel was alluding to, and how much our hospital is an organism of a kind, right? Every moving part coming together, communicating with each other, and making sure that things move forward. Communication is absolutely key. The nurses and our other frontline healthcare worker staff were absolutely afraid, very much like the AIDS era. And being able to communicate with very strong leadership, which we have, putting out a education almost as immediately as possible. I mean, once you saw our healthcare workers getting educated, we employed an electronic system by which we were able to have all of our healthcare workers acknowledge that they had seen the video, been educated on Ebola, and then as we came up with PPE training, people also were asked to watch these, and you could just see the temperature come down with regard to fear and anxiety as soon as that type of communication occurred. Right. It's just absolutely critical. And the other thing I'll say in terms of education and communication is the training, the in-person training, how much that really matters in an ongoing fashion so that complacency doesn't take hold, so that Ebola has really asked us to take a look at all of our systems and how we can move forward, every couple of months, sort of visit how it is we're going to manage training and keep all of this information fresh, and it really isn't Ebola specific.
Yeah, those are all very good points. I think the audience would be surprised also to find out that although Ebola's been around for 40 plus years, after 9/11, for those of you who are interested in this, we had some meetings to decide on what were the agents that could be weaponized that might hurt our country. And there was a list put out called select agents. At the time it was confidential, it's not now, but basically, and Ebola was one of those agents. So the point I make is that we actually had a lot of information about Ebola because it had been looked at by our scientists, because when we thought of our adversaries at the time, well, what might they use to try and hurt us? Everybody heard about smallpox and so on, but there were some odd viruses that you haven't. There's Marburg virus and things like that could be weaponized. So we started to think about how could we prevent something like that from happening. So we had some institutional memory for that, not in this case as a naturally occurring, but for terrorism. And we had an infrastructure, again, an all hazards infrastructure that was put in place to be able to address these issues should something like that happen, whether it be man-made or whether it be accidental or a mutation or something like that happen. Nevertheless, because we became somewhat complacent over those 10 years and let our guard down and didn't think about it, it snuck through and a patient did get here. And so I think it's an opportunity now for us to really recommit to patient safety, and probably no more important patient safety component is this emergency preparedness, all hazards and so on, because there will be another pathogen that's going to come our way in 6 months, a year. It doesn't make any difference. We have a history of pathogens coming. And so we have to keep it on the forefront. And again, we start to see, for me, Joe, especially, how big this whole patient safety movement is growing. It's much wider than where we just started with hospital-acquired infections or operations on the wrong side of a person or the wrong operation being done or a medication error. It's really morphing into something much larger now that includes our all hazards response and preparedness. Marleece, a question I have for you as a global practitioner and having clinics all over the world and people all over the world. And it's something like this, when do you call your people in? When do you say, okay, I'm bringing you out of West Africa. I don't want to take any chances.
Well, we actually did not allow any workers in West Africa during the height of it. Okay. And we revisit that continually, whether or not we would allow people in or not. And we had to put specific conditions. We did allow some workers to go in, but they were going to be monitored for the period that they came out. And fortunately, operations in that area right now have been minimal.
Okay. And then as it relates to the all hazards preparedness, and I'll go back to Arun right now, and a public health your infrastructure, you don't directly control. You have EMTs, paramedics, first responders, who are the first ones on the scene, who have to know how to use that personal protective gear. What was interesting, although we lost the capacity in many hospitals because they haven't practiced for a while with personal protective gear, taking it on, taking it off, what the risk was, we did retain it in society. Our EMTs, paramedics, and firefighters put that stuff on every day, and they respond to hazardous materials calls. So it is very similar to a pathogen call. So there is a repository of information, of expertise, so that when we started thinking about, okay, who's going to do all the refresher courses, we have people that do this all the time and are very expert in putting things on and off and how to minimize their risk. How was it for you in Los Angeles? How was that interface with all of our first responders who are going to be the first on the scene for these problems?
Well, for us, it was actually, for our department, it was fortunate that the EMS, Emergency Medical Service, is actually a division of our department. So it was something that we were in direct and frequent contact with. But overall, in Los Angeles County, the county convened a task force that had representatives from every one of the various agencies that might take care of a patient or have, sort of medical, clinical contact with Ebola in some sense. So it was police, it was fire, it was, the EMTs, it was Public Health Department, Department of Health Services, mental health, all of those folks. And we all met several times to think about what kinds of things that we would encounter, what kinds of things we either needed to know from other people or could use as help from other people. There were several departments that approached us and said, hey, can you tell us about, give us education about something, can you help us with finding a place to put someone if they need to be quarantined? And so there was a lot of cooperation, at least in Los Angeles County. We're fortunate that we have a lot of resources for that.
Well, I think the underscored message I hear from you is that patient safety is a multidisciplinary response. It's not about docs and just nurses or technicians. It's about everybody who has the privilege to serve our fellow citizens that we call patients. And so it's a team that comes together. Just like here, we have multiple disciplines out here to be able to do that. Shruti, talk to me a little bit. You're an infectious disease practitioner at a big university hospital. There was a big push for centers to become Ebola centers, remember, afterwards. And we saw what happened in Texas, unfortunately. They kind of imploded because no one wanted to go in the hospital after they took those patients. So how do we serve the public and get these centers of excellence, of which we have 4 in the country already? And those were designated back in the last decade because of bioterrorism, but yet they're still centers of expertise, NIH being the center. But how do we go about making sure we have those critical infrastructure hospitals and yet not undermine their ability to do their business during good times when they're taking all the high-risk patients?
Well, you're hitting on a very critical issue. I always say that with Ebola, the rarity with which we would expect to see it in this country and in our hospitals is juxtaposed with sort of the rule-out cases. You have a person who comes in from West Africa, they have a fever, they might be exhibiting signs and symptoms that could fit Ebola, but really they have malaria. Or really they happen to be a lawyer, they happen to be across the world, and they didn't really go into places that were high risk for infection, and they come in and they have some chest pain, and maybe they have some fever too, but they were in West Africa, and they happen to be within those 21 days. How does a hospital do its regular business of taking care of patients safely when you've invoked this other issue that then may sort of compromise their care because you have to invoke all the other personal protective equipment? And so that was a real struggle in trying to figure out how to deliver care effectively in a timely manner to every patient, regardless of their symptoms, and where do we do our labs exactly, and who's going to do the labs, and are there ways that we can build up the physical location so that we can manage the care of this patient? And do you intubate a patient like that if they need it, and if so, under what circumstances, and how do you do that safely for both the healthcare worker and to make sure that you don't come down with something and transmit it to patients? So lots and lots of struggle with regard to every single aspect of clinical care. And The use of technology also intersects there. Can we use video conferencing to interview patients who may be at risk for Ebola, suppose? Can we use electronic medical systems to flag a patient that might be a risk patient so nobody just walks in?
Yeah. So I think, based on your comments too, we need to do a better job of improving the health literacy of society,
Right.
that they understand the complex issues, that they feel comfortable that there is an infrastructure in place with experts like all of you to do this, and that when we have these centers of excellence who are willing to take added risk, that people should not be afraid to go there because it's an infrastructure that it compartmentalizes these problems so that our patients are not exposed during those times. So I think that would help to defray a lot of the challenges that we are having today and just the uncertainty that the public has. So as we close now, I want to thank you all for your unbelievable insight into these problems and helping our colleagues in the audience understand, and thank Joe for the opportunity to add to patient safety through this important panel and using Ebola as a teachable moment as it relates to all hazards preparedness and being able to have an infrastructure that the people would be happy with and understand that the nation is functioning optimally on their behalf. Thank you all very much. Thank you. Hey, Arun, thank you. Thank you, Shruti. Thank you. Please, go ahead.